Okay, good afternoon, good evening, everyone. No, so today we're gonna discuss um, pharmacology, drugs acting on the central nervous system. So today we're gonna discuss cardioglycosides and anti-anginal agents. But I'm gonna start this day or this lecture mostly talking about the anatomy. This will lay down the foundation, of the following next topics, so that it's easier for us to understand. So let's begin. So let's start with the anatomy now. As we know, this is the heart, no? It is made up of four chambers. Okay, four chambers. And these chambers are subdivided into two parts. The top one, the one on top, no, is what we call the atrium or the atria. Okay, kaning natin is this one and this one. These are what we call our receiving chambers. So they will receive blood, no? Oxygenated for the left atrium and unoxygenated for the right atrium. And then we also have the bottom ventricles, bottom, which is our ventricles, no? Our ventricles are what we call the pumping chambers, no? They are the pumping chambers. They are responsible for pumping blood towards our great vessels. So for example, the right ventricle will pump blood towards the pulmonary artery, while the left atrium or left ventricle will pump blood towards the aorta, no? So na siya. So our heart is made out of cardiomyocytes. It is a muscular organ, mga goods. It's made out of cardiomyocytes. Now, cardiomyocytes are cells, no, or muscle cells of the heart. They are the ones responsible for contraction. So they are the muscle cells of the heart responsible for contraction of the heart. Another recap that we need to make is the circulation through the heart. So unoxygenated blood enters the heart through your vena cava, superior and inferior, and enter into your right atrium. Once that it enters the right atrium, it will go to your right ventricle, and then after that, it will be pumped through and towards your pulmonary artery. Your pulmonary artery class, no, will then send that blood towards your lungs, so that it will become oxygenated. And once it is oxygenated class, the oxygenated blood, ang kanang blood nga na oxygen, it will come back to the heart through your pulmonary veins. There are four. Okay? Through your pulmonary veins and into the right atrium, down into the left ventricle, and then pushed or pumped into your aorta, and then into your system. So mo na siya ang atong circulation. Okay. Now let's talk about conduction, no? Our conduction, our heart has the quality of what we call automaticity. Okay? Automaticity. Meaning to say it is able to create its own electrical impulses by itself, no? So this is very important, class, because the contraction cycle revolves around our electrical impulses. However, the rate at which these impulses act, no, is highly dependent on our autonomic nervous system. Autonomic nervous system. Okay? Now, our autonomic nervous system is divided into two parts. Number one, our sympathetic and our parasympathetic. This is what we call our fight or flight. And kining usa, class, this is for rest and digest. Rest and digest. Okay? Now, the SNS, no, is activated by our catecholamines, our epinephrine and norepinephrine. When our epinephrine and norepinephrine bind to our beta cells, beta 1 cells specifically, they will have an effect of increasing the heart rate. Mupaspas ang imong heart rate, no? Our peripheral or parasympathetic nervous system, which is for rest and digest, is activated by vagal stimulation or stimulation of the what we call cranial nerve number 10, the vagus nerve. If this is stimulated, class, it will cause our heart rate to decrease. It will cause our heart rate to decrease. Now there are two main organs, no? Two main conductive organs found in your heart. First is your SA node, kinesiya. this one here, the SA node. Now, the SA node, the one encircled in green, is our primary pacemaker, and it is the one that generates electrical impulses for our heart. Primarily, it will generate an electrical impulse 60 to 100 times per minute, which is very familiar because this is also our heart rate, di ba? This is also our heart rate. So each impulse is equivalent, each electrical impulse is equivalent to one cardiac cycle. One cardiac cycle. Okay? Now the next part here is our AV node or atrioventricular node. Okay, kini siya sinoatrial, kini atrioventricular. Now the atrioventricular node, this one here, has two functions. The first function is that it will send the impulses from the SA node down towards your vertical ventricles, no? It will send those electrical impulses down through your bundles of His and towards your what we call Purkinje fibers. That is its first function. Another function is that it will act as a secondary pacemaker. What I mean by that is this. Sometimes, class, our SA node could be damaged or defective, or it may not work. No, so what happens is the AV node will take command. No, instead of shutting down your heart, no, the AV node will instead generate the impulses for your heart, so that nagyapon kay contractions. No. However, it is only limited to 40 to 60 beats per minute, so it's not enough to sustain life, but it is enough to keep you alive long enough until na ay intervention. Okay? These electrical impulses can be recorded using our ECG or our what we call electrocardiogram. Okay? Our ECG class will record rhythm and rate. Rhythm and rate of electrical impulses. Okay? Sige, let's continue. Let's start with our regulation of heart rate and blood flow. Now, let's talk about this first, no? Let's talk about cardiac output. Now, cardiac output is the amount of blood ejected per minute. Okay? Normally, it is around 4 to 10 liters per minute. However, that is subject to change. Nga naman, normally it is 4 to 8 liters. Because our cardiac output, mga good class, is a formula. And this formula includes heart rate times stroke volume. Okay? Heart rate times stroke volume. Now, we already know about heart rate, diba? We are very familiar with this, no? So, heart rate is normally 60 to 100 beats per minute. It is dependent on the autonomic nervous system, no, to regulate its pace. So mo na siya, if SNS gani increase, if PNS gani decreased. However, class, let's talk about stroke volume. Okay? Now, stroke volume is the amount of blood ejected per contraction. So mo ni siya ang kadaghanon sa blood or the milliliters of blood that is ejected every time the heart contracts. Okay? Now, this is also a formula, class. And the formula for this one is ESV minus EDV minus ESV is equals to stroke volume. So, what do this mean? When we say EDV, it means end diastolic volume, while ESV means end systolic volume. Now, let's talk about this, no? Let's talk about this while we are talking about the three factors that contribute to our stroke volume, namely our preload, our contractility, and our afterload. See, ato na discuss. Here we have a model of the heart. Okay? Isa siya, model of the heart, no? Now, listen to me, ha? I will draw blood in blue para maklaro siya. This one, blue. Like that. That's blood. Okay? Now, listen, ha? During the diastolic cycle, okay? When we say diastolic, class, this is during the relaxation cycle of the heart, no? Blood will enter your right atrium or left atrium. Depende, no? most of the time it enters both, no? Actually, it always enters both, no? So, ano lang, ang ato ng example karon ang right atrium lang. We're just gonna use the right for an example, okay? During the start of the diastolic cycle or diastole, it will enter the right atrium. Now, during the end or near the end of diastole, this blood will now move towards your right ventricle. Okay, so during the end of diastole, most of the blood will already be here at the right ventricle. Okay, most of it will already be here. Now, if that is the case, class, no, if that is the case, this is our ESV. Okay, this is our ESV. This is the amount of blood. ESV literally means the amount of blood in the ventricles. I know, not ESV. Gago. It's EDV. EDV. It is the amount of blood in the ventricles after diastole. Okay? And normally, ESV is around 130 ml. ESV is around 130 ml. Now, here's my question to you, class, and I want you to answer it properly, okay? Here's my question to you, and I want you to answer it properly. Di mo katubag, gago, normal, no? So, just answer by yourself, no? So, if kaya ni mo, class, no? Since this is, there is blood here, there's blood here, no? Do you think that this will expand the blood ventricles? This will expand the ventricles. Yes, no, mura na siya. It's like a balloon, kasi when you fill a balloon with water, obviously the balloon will expand. The same goes with your heart, no? If you fill the ventricles with blood, no? Obviously, then the ventricles will expand. This is our first factor, class, which is preload. Okay? Preload refers to the amount of blood that stretches the ventricles. Okay, the amount of blood that stretches the ventricles. So, obviously, class, at sige lang, ato lang na-explain na ka ng PR, cardiac output later. Okay? Obviously, the more blood, no? The more blood that is output from the heart. Now, as this stretches, class, no? As this stretches, no? This is what we call our preload. If the ventricles stretch out, class, that is what we call our preload. It is the preload before it is fired into your great vessels. Okay? Now, that is for preload. Next factor, class, is contractility. We have a thing kasi, class, we call the Frank-Starling mechanism. And the Frank-Starling mechanism, class, basically means that the greater the ventricular stretch, no? The greater the preload, the stronger the contraction. The stronger the contraction. So the more blood that is in your ventricles, the greater the stretch, and then the greater the contraction. Mas kusog ang iyang contraction, is much more stronger. Now, let's talk about contraction, no? Contraction. Now, during the systolic cycle, listen ha. During the systolic cycle, okay? Or otherwise known as the contraction cycle, the blood here, okay, will be moved towards the great vessels during contraction. Diba? Contraction will decrease the size of the ventricles. It will pump, no? It will pump the blood going upwards towards the great vessels. Now, the problem there is this. Muna siya ang problema na, class. Most of the blood will enter, no, your great vessels, but not all of them. Naatay mabilin diri, class. There is a few milliliters, no, that will remain. Okay? Now, this is what we call our ESV, or the amount of blood after, in the ventricles. In the ventricles after contraction, otherwise known as systole. Okay, so this is the amount. Typically, the ESV is around 60 ml. Okay, 60 ml. So kadaghanan sa blood class, most of the blood has already entered the great vessels, no? Either the pulmonary artery or the aorta, no? Depende na niya. However, naadyo niya mabilin, there is always a few mLs that will remain in the heart, no? So that is our ESV. And if we look here, our normal EDV is 130 ml, di ba? Minus the normal ESV, which is around 60 ml. Okay? 60 ml na siya class ha, normally, no? So if we subtract that class, we get 70 ml. 70 ml class is the normal stroke volume. So every time your heart contracts, 70 ml of blood is being ejected by the heart. 70 ml of blood is being ejected by the heart. Okay? So let's talk about the last part here, which is afterload. Now, afterload class is, to put it simply class, it is systemic vascular resistance. Okay? This is the resistance that the blood has to counteract, no? In order to flow. So, for example, class, here's my example of what we call afterload. Now, let's say, for example, the blood is here in the left ventricle. When it contracts, class, most of the blood, as I mentioned, will be able to flow freely through your aorta. Now, that's normal. That's normal, okay? That is normal, class, no? It should be able to flow freely. Now, let's say, for example, here in your aorta, class, there is a tumor. Sinasin mo aorta na ay tumor, no? There's a tumor inside the aorta, no? Stang paita. Now, during contraction, class, the blood will still be able to flow. The blood will still be able to flow, but it will not, all of it will not flow, and it will have a hard time flowing because there is a tumor here. So, not all of it will be able to flow. And this is what I mean by resistance, class. It is a resistive force, no? It is something that is blocking, no? Blocking the blood flow. Now, if there is an increase in afterload, okay, such as there is a tumor, no, then there will be a decrease in cardiac output. And this is vice versa, class. If there is a decrease in afterload, then there will be an increase in cardiac output. Okay? Same goes with preload, class. If preload is increased, like for example, class, if there is 200 ml of blood here, 200 ml, no, then there will also be 200 ml or at least 180 ml that will be moving towards your great vessels, no? So there is gonna be a decrease in cardiac output. There is gonna be a increase in cardiac output, and it's also vice versa. Okay? Ayan. So that is regulation of the heart rate and blood flow. Now, our first drugs for today is our cardioglycosides. Cardioglycosides or cardiotonics, these are drugs that increase the force of heart contractions, no? They will increase the strength of contractions. Usually, class, these are drugs that are made for heart failure. Okay, heart failure. Now, this is very difficult to discuss. It's very difficult to discuss, class, if, for example, we don't know what heart failure means. So let's discuss heart failure. Now, this is the normal heart, and the one on the right is the heart with heart failure. Now, I want you to see, no, the major difference. The major difference there is this. There is a thinning of the walls, no? There is a thinning of the walls in your left ventricles. Now, there is a thinning of the walls in your left ventricles. Now, the problem there is this. If the walls are thinned, then the walls or the ventricles are weakened. Okay, weakened na sila, class. And if they are weakened, class, then the contractions are weak. Contractions are weak, no? The problem there is this. As we know, blood enters your right atrium. Blood enters your right atrium and down to your here, no? Your left atrium and then left ventricle, no? Once you push it up, class, once it contracts and pushes it up towards the aorta, no? Some of it will flow freely. Because there is still contractions, di ba? Naagya po yung contraction. Some of it will flow freely. However, some of it will not be able to flow freely, and instead, listen to me ha, I will put this in green, no? Some of them will stay here in your atrium because the pump is not strong enough. So na mabilin dire. There will be some back here. And eventually, if it persists, no, some of this blood that stays here will backflow towards your lungs. And that is a big problem. No, dako ka na siya na problema, class, because it can cause your lungs to increase their what we call pulmonary vein pressure, no? And if there is increased pressure in the pulmonary vein, no, blood tends to leak out of the blood vessels and enter the lungs, no? So ang ending na class, malumos ang imong lungs, or you will be flooded with blood in your lungs. So the main problem with heart failure is that there is weakened contractions, which leads to backflow of blood. Okay? Now let's continue, no? So that's the problem, no? The main problem is weakened ginatong contractions. Our drug of choice, no, for drug of choice, no, or most common drug for heart failure is our digitalis digoxin. Okay? Now, before I discuss to you the mechanism of action, let's talk about the cardiac myocyte first. The cardiac myocyte, okay? Let's say, for example, this is the cardiac myocyte, okay? Sayang. Okay? This is the cardiac myocyte. Let's say, for example, this is the cardiac muscle cell, no? The inside of the cardiac myocyte is called the intracellular space, while the outside is called the interstitial. Now listen to me ha, this might get a little bit complicated, so focus, okay? Inside the cell, there is a lot of potassium, there is a lot of magnesium. While outside the cell, there is a lot of sodium, there is a lot of calcium. Okay? Calcium. Now, during the, listen to me, during the repolarization phase, also known as relaxation phase, okay? The potassium and magnesium is inside the cell, while the sodium and calcium is outside the cell, no? So, inside the cell, it is negatively charged, no, when it comes to voltage, negatively charged, while the outside of the cell is positively charged. Now, that is for relaxation. Now, listen to me, ha? If calcium enters the cell, no, then it will cause contractions. If calcium enters the cell, then it will cause contractions. Now, here is what's gonna happen. Muna siyang may tabu, class. Listen, ha? Listen. During the depolarization phase, otherwise known as your contraction phase, sodium class will enter the cell. Okay? And once sodium enters the cell, potassium exits. Mugawas ang potassium. Magnesium also exits. Because sodium entered the cell, calcium, which follows sodium, no, will follow going into the cell. Now, since calcium is inside the cell, listen to me, ha? Since calcium is inside the cell, it will turn the polarity of the cell into a positive one. So, positive na siya ang imong cell. Positive na siya. Negative na ang gawas. And because, class, as I mentioned before, calcium is in the cell, it will cause a contraction. It will cause your heart to contract. Okay? Now, basically, class, ang imong relaxation contraction cycle is just this. The entering and exiting of the sodium and calcium. Now, If, for example, the calcium stays in the cell, then that is bad, no? Bati na siya, class, because it will cause your heart muscles to constantly contract. Magsigira na siya contract, class. So, muna mapaspas yung heart rate, no? Magsigira na siya contract. So, what do we do in this instance? Luckily for you, ang atong lawas already has a mechanism for this. This is what we call our sodium potassium pump. Now, what it does, I want you to listen, what it does is after the depolarization phase, it will pull sodium back in, or potassium back in. It will pull potassium back in. It will pull magnesium back in. Okay? And then, it will send sodium out. After depolarization, it will send calcium out. What happens when that is reversed is that the polarity also reverses. No? The polarity also reverses. So, what happens there now is negative na ni siya, class, and outside of the cell is now positive. We have now reached the point nga ni relax na pud balik ang atong heart muscle. The heart muscle has relaxed once again. Okay? So, that is a normal heart muscle. What digoxin does is that it will inhibit or stop the sodium potassium pump. So, yan ay stop. Okay? Resulting in an increase in intracellular sodium. So, sodium will be staying inside the cell. Sodium will stay inside the cell. And because sodium is inside the cell, calcium is also inside the cell. Calcium will also remain inside the cell. Because calcium is increased inside the cell, this will cause the muscle fibers to contract more effectively. It will contract more effectively. So, muna siya, that is what's gonna happen. Okay? So, muna siyang action sa atong digoxin. Because the calcium remains in the cardiac myocyte, then it causes the muscle cells to contract more effectively. Now, digoxin has a few effects. Number one, it has an inotropic effect, a positive inotropic effect, meaning to say it will increase the strength of contractions. A negative chronotropic effect, which means it will decrease the heart rate, no? Chronotropy means the rate of contractions or heart rate. And it also has a negative dromotropic effect, which means it will decrease the electrical conduction of the heart. Okay? And because of that, no, our digoxin is indicated for heart failure. Because as I've mentioned before, the problem with heart failure is weak contractions. And our digoxin has a positive inotropic effect which will increase the strength of contractions. Diba? Very simple, no? While digoxin is also used, no, for atrial fibrillation and atrial flutter. Now, AFib and aflutter, no, these are what we call tachyarrhythmias. Basically, they are ECG patterns that are abnormal. When we say tachyarrhythmia, class, these are arrhythmias that are very fast, around 200 to 300 beats per minute. And because of that, class, no, we can use our digoxin to slow down their heart rate and to decrease the electrical conduction. Obviously, we want to slow down the heart rate and the conduction because the heart rate of these ECG patterns are very, very fast. Pas-pas kayo ang iyang heart rate, no? So that's why we can use it. Now, digoxin also has a therapeutic level because it has a very narrow therapeutic range of around 0.8 to 2.0 nanograms per ml. If over 2 nanograms per ml gani na, class, then they might get early signs of toxicity. Okay? Early signs of toxicity. Now, this is our BANDAV class, no? BANDAV, B-A-N-D-A-V. No? Our bradycardia, anorexia, nausea and vomiting, diarrhea, abdominal pain, and visual disturbances. Now, since this is toxicity class, no, you have two choices. No, number one, you can tell the doctor, no, and then I'll stop the medication and then tell the doctor, or no, In the case of digoxin, the thing you need to do is you need to give them their antidote. Now, what is an antidote, class? An antidote is a drug that reverses the effect of another, no? So if digoxin becomes toxic, class, we can give them an antidote so that it will reverse the effect of digoxin. Now, these are the early signs, kani. These are the early signs, no? We also have late signs, class. Our first degree heart block, second degree heart block, and complete heart block. Now, you'll learn more about those in your medical surgical nursing, no? So abangan nyo yan, okay? Now let's have a quick question, no? What early signs and symptoms should the nurse assess for a patient taking digoxin that should indicate toxicity of this drug? Select all that apply. Dysrhythmias, yes or no? No. Anorexia, yes. That is our second A, our first A. Drowsiness, no. Nausea, yes. Vomiting, yes. So ang answer, ani class, is B, D, and E. Okay? B, D, and E. So mo na siya, class, no? These are the type of questions na you should be familiar with. This is the type of questions that we will tackle, no? Mostly. This is the type of questions that we will use in our exam. Okay? So mo na siya, no? Digoxin. The antidote for digoxin is called our Digibind. The Digibind, or otherwise called your Digoxin Immune Fab. Digoxin Immune Fab may be given to treat digitalis toxicity or digoxin toxicity. What it does is it will bind with digoxin molecules in order to prevent binding at the cellular site of action. So basically, if this is the digoxin molecule, what it does is the Digibind will bind, lumupilit siya sa imong digoxin. And if this is the receptor for digoxin, it will prevent the attachment of the digoxin to the receptor, no? So instead, it will be excreted in the urine, decreasing the level of digoxin in the blood. Now, what are the interactions of digoxin? Hold digoxin if potassium is low, okay? Such as during hypokalemia, because decreased potassium can increase, no? Decreased potassium increases the effect of digoxin, which leads to a higher chance of toxicity. So you need to monitor, no? Usually, class, potassium, the normal potassium is around 3.5 to 5.2. Diba? 3.5 to 5.2. So if the potassium is less than 3.5, then imuha na siyang i-hold. Do not give the digoxin. Hold, ha? Do not give the digoxin, no? Ato na mag-star. Okay? Hold if the heart rate is less than 60 beats per minute. Hold if the heart rate is less than 60 beats per minute, because as I've said, digoxin has a negative chronotropic, meaning to say it will further decrease the heart rate, no? So if the heart rate is already very low, then there is a tendency that if you decrease it some more, it might cause rampant bradycardia. If you are taking potassium wasting diuretics or cortisol, then encourage the patient to consume potassium rich foods. Now, potassium wasting diuretics and cortisol, they are drugs that will cause hypokalemia or decreased potassium. They will cause decreased potassium. And if the patient really has to take the digoxin, if no choice sila, class, they have to take the digoxin, then you need to, what we call, instruct them, no, to increase their potassium-rich foods. Okay? Potassium-rich foods include avocado, no, banana, and other tropical fruits. Tropical fruits na sila, no? So, imo na sila, you have to increase potassium-rich foods in order to prevent hypokalemia. Okay, another type of cardioglycoside is our phosphodiesterase inhibitors. Ato example ani class is our milrinone lactate, no? Milrinone lactate. Now, it has a positive inotropic effect, which we like because this will increase contractions, as I mentioned before. Increase contractions, but this will also cause vasodilation or the widening the widening of the what we call blood vessels. Now, because of that, class, the heart will compensate by increasing its heart rate. However, if you widen the blood vessels, manggod, if you widen the blood vessels, there will be a sharp drop in blood pressure. Naadyo na drop in blood pressure. Now, milrinone, class, what we need to remember is it has to be administered only up to 72 hours. So, dili pwede mo lapas, class, ha? Only up to 3 days. Okay? Monitor BP and heart rate while administered because as I've said, it changes, no? It decreases the BP and increases the heart rate. And then this may result in severe cardiac dysrhythmia. So, may result as a side effect. ECG monitoring is a must, class. Okay, meaning to say, dapat na adyo ECG. If the question about milrinone is this, if giving milrinone, what will the nurse prepare on the bedside? Okay? Ang answer ni mo na, class, ECG. Okay? Because you want to assess whether or not nagka-cardiac dysrhythmias na sila diha. Okay? And then, there are other drugs to treat heart failure, vasodilators, ACE inhibitors, angiotensin II receptor blockers, diuretics, spironolactone, and beta blockers. Although we will not discuss this today because these are anti-hypertensives. So, ato na, we will discuss this on, I think, the last meeting of cardio. No? The last meeting of cardio. Okay. Sige. Mag-breaks ako. 10 minutes. And then I will send another video, no? Part 2 ani niya.